addressing the unique needs of persons served. Understanding disabilities. Course description. This course will educate participants about the unique needs and preferences of clients and explore varying cultural perspectives regarding treatment. The course will assist the learner to better understand and respond to cultural differences, perspectives, and responses to treatment. After reviewing this training and successful passing of the quiz, you'll be able to make every effort to be competent in addressing the special circumstances that affect clients, understand the range of client reactions to the challenges associated with particular special circumstances, identify limits of one's own knowledge and understanding, and evaluate personal beliefs and biases about clients who have special problems. Understanding disabilities. There are many kinds of disabilities. Disabilities can be visible, hidden, permanent, or occur only at certain times. Examples of disabilities include hearing, intellectual, developmental, learning, mental health, physical, speech or language, or vision. Mental disorders. Understanding the challenge. Most persons with identified mental and co-occurring disorders respond positively to treatment. Although genetics do influence the development of some disorders, mental disorders in parents do not necessarily mean the children will suffer from a mental disorder as well. Mental disorders. What you should know. Mental disorders affect one's thoughts, moods, and emotions. Early identification, completing appropriate assessments, and effective individualized care planning can make a tremendous difference in treatment. Each disorder is different, and each person expresses a disorder uniquely from anyone else. Disorders can become more or less severe and may change over time. Persons living with mental disorders can learn to function positively and effectively in their communities. Violent behaviors are not associated with all disorders. Having a mental disorder does not mean a person cannot raise a child safely and successfully, and background and environmental challenges can affect the way a person expresses their disorder. Providers should know that persons with mental disorders may become isolated from informal supports. They may not recognize their poor judgment. They may turn to negative sources of support. And persons with mental disorders may not recognize any impact on their children's and/or other family members. Dually diagnosed. Dual diagnosis refers to when someone has both a substance use disorder as well as a psychological disorder, also known as co-occurring disorders. Individuals diagnosed as dually diagnosed need to be treated for both addiction and mental illness simultaneously in order for them to get better. Dual diagnosis. What a provider should know. It is important not to overlook existing substance abuse or mental health issues. You must recognize the symptoms. You should rather rule out rather than in. Identify probable cause to address the problem and behaviors. Know that many symptoms can manifest in behavior issues. Understand what the individual is trying to tell you. And if someone appears to be in a crisis, ask them to tell you the best way to help. Identifying unique needs of clients. Physicians should work towards reducing any identified barriers that may keep a client from functioning at their optimal level in their communities. Issues that may affect persons served are physical, behavioral, educational, and cultural. Diverse populations. Diverse populations include, but are not limited to, Hispanics and Latinos, African Americans, Native Americans, Hindus, Asian Americans and Pacific Islanders, persons with HIV/AIDS, lesbian, gay, and bisexual populations, persons with physical and cognitive disabilities, rural populations, women, homeless populations, and older adults. Diverse populations, immigrants, and refugees. Providers should be familiar with diverse populations. Common characteristics of immigrants and refugees: mistrust of authorities, Immigrants and refugees may feel extreme mistrust of the government based on the atrocities committed in their countries of origin or fear of deportation by U.S. authorities. This mistrust can be a barrier to entering treatment and obtaining services. Diverse population, dealing with stigma. According to the U.S. Department of Health and Human Services, clients from other cultures view mental disorders, including substance abuse, much more negatively than the general U.S. population. Diverse populations, lesbians, gays, and bisexual clients. LGBT individuals come from all cultural backgrounds, ethnicities, racial groups, and regions of the country. Cultural groups differ in how they view their LGBT members. In Hispanic culture, members of sexual orientation tend not to be discussed openly. LGBT members of minority groups often find themselves targets of discrimination within their minority culture and of racism in the general culture. Diverse population, rural population. Common characteristics of rural populations. Concerns about confidentiality and resistance to participating in group work because in small communities, everyone seems to know everyone else. A culturally embedded suspicion of treatment for substance abuse and mental disorders, although this varies widely by area, and a sense of strong individuality and privacy, sometimes coupled with a difficulty in expressing emotions. Diverse populations, persons with physical and cognitive disabilities. The combination of depression, pain, vocational disabilities, and functional limitations places people with physical disabilities at an increased risk of substance abuse disorders. Diverse population, HIV/AIDS. Common characteristics of persons living with HIV/AIDS. Clients with HIV/AIDS often present with a cluster of problems, including poverty, indigence, homelessness, mental disorders, and other medical problems. Diverse populations, African Americans. Common characteristics of African Americans. Mistrust, rely on faith, family members, or emotional support rather than turning to healthcare professionals. Mental illness often is perceived as personal weakness or some sort of punishment from God. May be reluctant to seek and discuss mental health issues and seek treatment because of the shame and stigma associated with such conditions. Among African Americans with a perceived need for substance abuse treatment, 25% reported the need was unmet, more than twice the number of whites who reported an unmet need. Diverse population, homelessness. Common characteristics of the homeless population. Recently displaced. Some people may be employed but have been evicted from their homes. Their housing instability may be related to financial problems resulting from substance abuse. Chronically homeless. These individuals may have severe substance abuse and mental disorders and are difficult to attract into traditional treatment settings. Transient. These individuals may stay temporarily with others or have a living situation that involves rotating among a group of friends, relatives, and acquaintances. These individuals are at high risk of suddenly finding themselves on the street. For some, continued living in other people's residence may be contingent on providing sex or drugs. Diverse culture, women. Women, treatment should be sensitive to cultural customs and roles that females have in other cultures and to the client's level of acculturation. It is important to understand the client's level of comfort with what is expected in treatment. Treatment goals should depend on the woman's hopes and should conform to the cultural role that she would like for herself. Diverse culture, older adults. Older adults tend to feel shame about substance use and are reluctant to seek out treatment. Many relatives of older individuals with substance use disorders are also ashamed of the problem and rationalize the substance use or choose not to address it. Older individuals tend to not see themselves as abusers, particularly those who misuse over-the-counter or prescription drugs. Cultural difference, example number 1. Substance dependence. In some Asian cultures, the stigma is so strong that a person's substance dependence is thought of to reflect poorly on the family lineage, diminishing the marriage and economic prospects of the client and for other family members. Cultural difference example 2. The use of substances. Many Native people use what they consider natural mind-altering drugs in a sacred way under special conditions as a part of traditional rituals. However, this is very different from recreational usage of the drugs for personal pleasure. Cultural difference number 3. Medication use. Traditional Hindu practices do not accept the value of drugs to treat certain physical health conditions. However, the medication is often seen as more of a secondary or temporary tool for health, not the first line or primary approach. Overcoming stigma. Assume control, manage symptoms, and become an empowered individual. Common myths. 2 common myths to debunk. People with disabilities are inferior to normal people and their lives are very different. You have to be careful when you're talking to a person with a disability because they are easily offended if you use the wrong word. 8 wellness dimensions. The 8 wellness dimensions are as follows: emotional, environmental, intellectual, financial, social, spiritual, occupational, and physical. Communication matters. As a provider, you should assume intelligence. No nonverbal interactions can lead to inaccurate and harmful assumptions about a person's cognitive ability and competence. Work to open new avenues of respectful interactions with persons served who struggle with language. Should know if we change how we talk, we can make positive changes, and give the client a chance to communicate and not just answer questions. Focusing on positive attributes. Focusing on the strengths of a client is an effective treatment intervention. Be supportive. Put on a different lens and attempt to see things from a different perspective. Do assessments in a new way. Look at what's going right. Find out what makes the person comfortable. Look at ways to incorporate strengths into treatment strategies. What strengths can be used effectively in a treatment? Respectful support. 6 respectful, supportive interactions. Understanding of treatment modality. Self-directed choice. Build relationships. Encourage community membership. Demonstrate patience and understand the language. Making incorrect assumptions. Always remember, just because a person has one disability does not mean they have another. For example, a client has a difficulty speaking. Don't assume that the client has an intellectual or developmental disability as well. Resistance to treatment. Many times providers believe that they know what is best for the client. You must know that treatment is the person's choice. Treatment is different for person to person. Reinforcement and support is important. Address any stressors. Oftentimes trauma can cause resistance to treatment. And poverty and lack of adequate housing can cause resistance to treatment. If this occurs, do not become overbearing or judgmental. Just find a different route for engagement. Understanding barriers. What are barriers? Barriers are obstacles, things that stand in the way of people with disabilities doing many of the day-to-day activities. Assistive devices can be put in place to minimize barriers and to maximize a person's safety without compromising their autonomy or dignity. Addressing barriers. Interventions and supports. Architectural and physical barriers. Architectural and physical barriers are features of buildings or spaces that cause problems for people with disabilities. For example, hallways and doorways that are too narrow for a person using a walker, electric scooter, or wheelchair. Counters that are too high for a person of short stature. Poor lighting for people with low vision, or telephones that are not equipped with telecommunication devices for those with hearing disabilities. Information or technology barriers. Information or technology barriers are those barriers that cause challenges in the day-to-day activities for those living with a disability. For example, signs that are not clear or easily understood, print that is too small to read, or websites that don't offer screen reading software. Attitudinal or systematic barriers. Attitudinal barriers are barriers that discriminate against people with disabilities, thinking that people with disabilities are inferior, and assuming that a person who has a speech impediment can't understand you. Systematic barriers are those barriers that occur when an organization's policies, practices, or procedures discriminate against people with disabilities. For example, a hiring process that is not open to people with disabilities. Sexuality and intimacy barriers. The desire to enter into emotionally satisfying and sexually intimate relationships and to maintain such relationships underpins the human adult experience. This includes persons living with mental health and physical disabilities. It is important to work with clients on developing social skills related to the pursuit of intimate relationships. The following can lead to challenges in treatments: confusing intimacy and loneliness with sexuality, not understanding isolation, being dismissive, and not addressing intimacy needs. Religious customs barriers. Do work to understand and accommodate the religious customs of individual clients. Do you ask about a client's dietary preferences, special holidays, and religious customs? Do you demonstrate religious acceptance and tolerance? Do you contact local religious leaders so they can educate you about traditions and practices and the use of mind-altering natural substances? And do you educate religious leaders about services that are available? Evidence-based practices, interventions and supports. Interventions and supports. Tips of useful interventions and supports: illness management, supported employment, individual placement and support, family psychoeducation, assertive community treatment, co-occurring disorders, integrated dual diagnosis treatment, medication management, counseling therapy, self-help groups, and residential or institutional care. Bringing it all together. Client role. The client should be informed choosers of care, participate fully in their treatment, motivate providers to improve their performance, and engage in effective self-care, taking preventative actions and collaborating with providers to define and implement care plans. Bringing it all together. Role of the provider. The provider should arm persons with evidence about treatment and risk benefits, react positively to persons who want to take the lead role in their treatment, use information gained from patient assessments of care as the basis for improvement, engage patients making informed decisions to improve both quality of care and health outcomes, tailor a care plan to a particular patient's needs, and continually measure how well a care plan is working. Encouraging client ongoing input. Ways to encourage client input for effective treatment. Try to find ways to provide information in a way that works best for the person. One way you can do this is have a pen and paper ready for your use. Be patient, encouraging, and supportive. If you are courteous and patient, typically the client will let you know how to best provide service in a way that works for them. Do. Remember when you demonstrate patience and a willingness to find a way to communicate. Those are your best tools. Speak normally and clearly and directly with the client, as they will be more willing to cooperate with the treatment. Do not rush. People with some kinds of learning disabilities may take a little longer to understand and respond to your questions.